Okay, so thank you, Michael. I'm Carl Borromeo. I've been here for 22 years. I've been doing liver transplants at Leahy since the onset of our transplantation program in 2000. So I have no disclosures. I'm going to be talking about cirrhotic cardiomyopathy from the perspective of a liver transplant anesthesiologist. So for a long time, for me at least, I equated cirrhotic cardiomyopathy to the relatively rare occurrence of postoperative systolic heart failure that can complicate liver transplants in 3% of liver transplant cases. The constellation of findings that otherwise make up this mostly subclinical condition, taken as a group, for me did not make a lot of sense. So without overt heart failure, I found it difficult to define cirrhotic cardiomyopathy in a way that was clinically accessible and in a way that was clinically useful. So my goals for this presentation are the following. Hopefully, after this, you'll be better able to better understand the updated cardiovascular parameters to define cirrhotic cardiomyopathy, to gain an appreciation for a more unified concept of cirrhotic cardiomyopathy. Importantly, outline the associations between cirrhotic cardiomyopathy and outcomes in two particular periods in our patient's timeline: pre-transplant or on the waiting list, or around the time of transplant. I also want to propose two things, right? Propose a framework of risk stratification that looks at the full spectrum of risk, not just the upper limits of risk for our patients presenting for transplantation, and also propose a more comprehensive cardiovascular evaluation at the time of transplant so that we can better optimize their treatment during transplant and better understand the natural history of cirrhotic cardiomyopathy, both before and after transplantation. So kind of recurrent theme here is that the transplant anesthesia is kind of different from your everyday general anesthesia. Transplantation presents unique challenges, and as transplant anesthesiologists, we necessarily think of cirrhotic patients differently compared to our every other day patients. Among the challenges I see are mainly three. Cirrhosis is multisystemic. It affects the brain, the heart, the lungs, the kidneys. And as Florian mentioned, the demographics of our patients are changing. Patients on the transplant list are getting sicker, they're older, and many have lifestyle-associated comorbidities. Again, another recurrent theme is that our time horizon with these patients is longer. We see them before they're transplanted. We take care of them for procedures while they're on the transplant list, for example, TIPS. We take care of them for their transplants, and then we follow them up long after they're transplanted. Finally, the MELD allocation system prioritizes the sickest patients. Think about that compared to like somebody who's undergoing hip surgery or elective knee surgery. We're really, for transplant, prioritizing the sickest first, obviously because they have the most to gain. So it's truly a high risk, high reward endeavor. These challenges necessarily affect how we practice. Our decisions that we make really have to be made in the context of an understanding of the natural history of both cirrhosis-related conditions and cirrhosis-unrelated conditions, with the expectation that most cirrhosis-related conditions will have a high likelihood of getting better after transplantation. Because these patients are captured for life, in addition to focusing just on getting them through the operation, we also have to think about longer term outcomes, 1-year survival, 3-year survival. And because the allocation system is already prioritizes the sickest, highest risk patients, we have to rethink preoperative strategies that focus only on establishing the highest limits, the upper limits of disease severity that preclude transplant, right? In other words, we need to think about delisting criteria, right? Which we definitely have for something like portopulmonary hypertension, and we're starting to formulate for things like acute on chronic liver failure. We need to think about changing how we think about their comorbidities. preoperatively, especially because a lot of what makes them so sick when they present to us will or should go away as they get a transplant. So, cirrhotic cardiomyopathy is progressive. It's initially subclinical with a progression of findings, starting with QT prolongation, then diastolic dysfunction, and even later we start to see systolic dysfunction. Okay, this progression really is based on prevalence of these manifestations, and rather than a unrelated syndromic constellation of cardiac manifestations, the findings that define cirrhotic cardiomyopathy in our current understanding are definitely interrelated, right? So for example, you look at systole and diastole, right? Systole and diastole are reciprocal processes. Mechanically, systole, not only mechanically, but also electrically, systole starts when diastole ends, and vice versa. So an abnormal relaxation and filling, an abnormal diastole, necessarily results in subtle systolic dysfunction that may not be detected by global indices of ventricular function. Heterogeneously arranged cardiac myofibrils contract in many dimensions. Systolic function, as measured by left ventricular ejection fraction, only measures radial myocardial contraction. As an example of this interplay between diastolic function and systolic function, take cardiac amyloid, right? A condition that we think predominantly as a diastolic disease with normal left ventricular ejection fraction. Cardiac amyloid is probably best or most sensitively detected using speckle tracking or global longitudinal strain, which is really a measure of regional systolic function. In addition, indices that measure a combination of systolic and diastolic dysfunction, like the TAE index or the myocardial performance index, have become very, very important in predicting prognosis in a variety of diseases. Secondly, we know that prolongation of EKG markers of repolarization, like, for example, QT interval, is associated with diastolic dysfunction, actually, in a variety of populations, reflecting some sort of electromechanical coupling during diastole. So electromechanical coupling happens not only during systole, but also during diastole. As measures of repolarization prolong, the severity of diastolic dysfunction worsens. Finally, these patterns of cardiac abnormalities that we see with cirrhotic cardiomyopathy are pretty stereotypic. You know, we see them we see a similar constellation of cardiac findings, specifically diastolic dysfunction, latent systolic dysfunction, and EKG abnormalities of repolarization in a variety of populations, including diabetics, hypertensives, probably even subarachnoid-induced stress cardiomyopathy. So this talk is really not meant to be a review of all the new cardiovascular imaging or biomarkers in cirrhotic cardiomyopathy. Rather, I'm going to focus on more contemporary definitions of the major features of cirrhotic cardiomyopathy. The major features as they were defined back in 2005, specifically diastolic dysfunction, LV systolic reserve or dysfunction, and QT prolongation. Kind of related to the QT prolongation, I will also talk a little bit about another EKG marker of ventricular repolarization, T peak to T end. So first, we'll look at grades of diastolic dysfunction. Sorry for the messy slide, but basically, by definition, grade 1 diastolic dysfunction is characterized by an isolated impairment of early relaxation. Take a look at the the second row here. Grades 2 and 3 diastolic dysfunction are marked by increasing the elevations of left atrial pressure due to increasing ventricular stiffness during the later phases of diastole. We are taught some of this early in our anesthesia training. Patients with poorly relaxing or non-compliant ventricles are more reliant on their atrial kick. You can see that here. So this is normal. A lot of velocity during the early portion of diastole, a little velocity during the atrial portion of the atrial kick portion of diastole. In grade 1 diastolic dysfunction with poor relaxation, you get a reversal of that. Little velocity during the early part, a lot during the atrial kick portion of it. Okay. Um, as the ventricles get stiffer, less compliant for a given end diastolic volume, the pressures increase. The left atrial pressures increase. It's initially the left ventricular end diastolic pressures increase. Those pressures are transmitted to the left atrium and pulmonary veins. As the left atrial pressure increases, the mitral inflow velocities will pseudo-normalize initially. This is grade 2, pseudo-normalization with increased pressures. Then later, as the velocity envelope reflects a higher pressure, higher gradient system, you start to see the grade 3 pattern, which is taller and narrow waves that are indicative of a restrictive pathology in the left ventricle. Echocardiographic diagnosis and grading of diastolic dysfunction is really based on 4 parameters, right? E prime, which is the third row here, E to E prime ratio, the early velocity, mitral inflow velocity, the big E to the E prime ratio, left atrial volume index, and TR velocity. The most important is the E prime, the tissue Doppler velocity of the septal leaflet of the mitral valve during the early phase of diastole. It is load independent and is of high velocity only in patients with normal diastolic function. E prime is decreased in all grades of diastolic dysfunction. So E prime is increased here in normal, decreased in all other grades of diastolic dysfunction. The next parameter is the ratio of E prime of E to E prime, E to E prime. If you look at 2 versus 3, the progression really is E to E prime is high, high, low, high, high, low, high, low. So it's only elevated greater than 15 in the last 2 grades, grade 2 and grade 3 of diastolic dysfunction. Left atrial, the last 2 things that we look at is tricuspid velocity and left atrial volume index. Left atrial volume index is a marker for chronic elevations of left atrial pressure, and the TR jet velocity is a marker for pulmonary hypertension. Both are also only elevated in grades 2 and grades 3 of diastolic dysfunction. We have to remember that TR velocity is a right-sided parameter. It can be high from both pulmonary arterial hypertension and also pulmonary venous hypertension. So it gets pretty complicated, obviously. So here is our the echocardiographic diastolic dysfunction grading system. As I said, it's pretty cumbersome. It can get pretty complicated, especially for those of us who don't do the echocardiography every day. But the take-home message for me is pretty simple. Higher grades of diastolic dysfunction, grades 2 and grades 3, are defined by indices that reflect high left atrial pressure. Almost all of those indices of left atrial pressure are left-sided indices, except for the TR velocity, which also reflects pulmonary venous and pulmonary arterial hypertension, as we discussed earlier. So my question to all of you guys is this: if you want to detect diastolic dysfunction in patients with normal systolic function and without significant valvular disease, which is most of the people we take care of for transplant, then obviously we have to look for indices that give us evidence of an elevated left atrial pressure. What is the easiest way for us to detect high left atrial pressure and also to differentiate between pulmonary arterial and pulmonary venous hypertension? In my mind, that's using a Swan-Ganz catheter. So despite the fact that we're all going to echocardiography, which we do for all of our cases here, I think there is room and there's utility to using Swan-Ganz catheters. So next, we'll talk a little bit about systolic function. LV systolic function conventionally is measured by echocardiography using left ventricular ejection fraction, which mainly reflects myofibrils contracting in the radial dimension. We know that myocardial fibers are arranged heterogeneously within the heart, with contraction occurring in multiple planes. The myocardium contracts circumferentially, it contracts longitudinally, radially, transversely. So echo strain imaging using speckle tracking can measure regional LV function in all of those planes. Global longitudinal strain, or GLS, tracks function in the most vulnerable endocardial myofibrils, and it's the most sensitive marker of contractile dysfunction. Global strain is usually measured using absolute numbers, with lower numbers denoting weaker contraction and higher numbers stronger contractions. Lastly, we'll look at EKG measures of repolarization, the most widely measured and studied being QTC. QTC is abnormal in a majority of patients that present for transplantation. Um, uh, it may actually predict post liver transplant outcomes. As I mentioned earlier, QTC correlates with severity of diastolic dysfunction in a variety of patient populations. And other measures of depolarization that better coincide with mechanical diastole show an even stronger correlation to diastolic dysfunction. More interestingly, a specific measure of ventricular repolarization, TPTN, has been shown to predict bad outcomes and mortality, not just arrhythmogenic mortality in a variety of populations like hypertensives, post-MI patients, and even the general population of people in Oregon. That is one of the measures that it's being looked at for predicting mortality in all of these different patient populations. So we've kind of gone over all of those parameters of interest. Hopefully, they're not as mysterious as they were to me. Hopefully, the features make a little bit more sense as a group. Hopefully, we understand better how interrelated they are. Now let's look at how these indices of cirrhotic cardiomyopathy have been implicated in the pathogenesis of poor outcomes in patients with cirrhosis. First, we'll look at patients on the transplant waiting list. Low indices of systolic function contribute to the genesis of hepatorenal syndrome in a variety of situations. Patients with ascites after spontaneous bacterial peritonitis and in an unselected population of cirrhotic patients with normal kidney function. Diastolic dysfunction here, specifically the persistence of diastolic dysfunction 1 month after the procedure, increases the risk of poor outcomes after TIPS, clearance of ascites, and survival. Diastolic dysfunction may also play a role in the overall survival of patients with cirrhosis. So given all of this information, it's very, very tempting to implicate cirrhotic cardiomyopathy in the development of acute unchronic liver failure. It is definitely a player in the pathogenesis of hepatorenal syndrome. It may be a player in the pathogenesis of congestive heart failure. So it's very tempting to implicate it in the development of acute unchronic liver failure. In fact, this relationship has been suggested in several studies. In our current understanding, there are two hallmarks that mark the transition from compensated or stably decompensated cirrhosis to acute unchronic liver failure, and those are hemodynamic changes and inflammation. Therefore, cirrhotic cardiomyopathy may play a contributing role in which patients on our transplant list ultimately present for transplantation. We'll discuss this a little bit more in 2 slides from now. So next, we'll talk about cirrhotic cardiomyopathy and its implications on outcomes perioperatively. So this is probably the most important for all of us. We think about how cirrhotic cardiomyopathy affects outcomes during and after liver transplantation. The relationship between cirrhotic cardiomyopathy and post-liver transplant outcomes is a little bit more complex because of three reasons, right? First, the cardiovascular imaging and tests that obtained at the time of listing can be relatively old by the time a patient comes to transplant. There may have been big cardiovascular changes in the meantime, especially in patients who have experienced some sort of decompensation. Secondly, as a measure of what is predominantly a cirrhosis-related comorbidity, we have a reasonable expectation that these changes will get better after transplantation. And finally, around the time of transplantation, the stakes are higher. We need to think not only about the outcomes of the patients in front of us, but we also have to think about issues surrounding futility and the utilitarian use of scarce organs. It is clear, if you look at this big chart here, that cirrhotic cardiomyopathy makes certain patients at higher risk after transplantation. But unfortunately, also evident from this chart is that as yet, we cannot set upper limits or thresholds of disease severity that precludes transplant, okay? Unlike in patients with portal pulmonary hypertension or acute on-chronic liver failure. So what are we left with when a patient with evidence of cirrhotic cardiomyopathy presents for either listing or transplantation? Before I get into that a little bit, there are a couple of articles I kind of want to review that highlight the issues discussed in the previous slide. The first article, Jensen's article, highlights the potential for a contemporary measure of contractile function, specifically global longitudinal strain, to identify listed patients at risk for decompensating and therefore needing transplant. The same marker, GLS, had no influence on post-transplant outcomes. Therefore, when this study, which followed a very specific transplant population throughout the whole transplant timeline, this particular marker proved to be a better predictor of decompensation and the need for transplant, rather than outcomes post-liver transplantation. The second article looked at a novel measure of ventricular repolarization in cirrhotic patients, T-peak to T-end, a measure, like I said before, that's been implicated in higher mortalities in a variety of patients. As I have alluded to, interestingly, rather than predicting higher mortalities, it actually, a prolonged T-peak to T-end was associated with improved survival. Maybe just reflecting, just like the first article, the possibility that some cirrhosis-related changes in the cardiovascular system reverse after liver transplantation. So it brings up the possibility that that there are markers of cirrhotic cardiomyopathy that may be used to identify patients who will do okay or maybe even better with transplantation. I'm currently working on a project looking at markers of repolarization in patients undergoing liver transplantation, and the results are very, very similar. Some markers of cirrhotic cardiomyopathy predicted worse short-term outcomes, specifically longer intubation times and higher incidence of a composite early organ dysfunction, but no differences in mortality and actually shorter hospital stays. Finally, summarizing everything, while on the transplant list, cirrhotic cardiomyopathy contributes to the development of hepatorenal syndrome. It contributes to worse outcomes following TIPS. And there are some studies suggesting a role in the pathogenesis of acute on-chronic liver failure. For cirrhotic cardiomyopathy in the peri-transplant period, this condition obviously confers increased risk in the perioperative period for prolonged intubation, graft failure, heart failure, and long-term mortality. Therefore, it behooves us to do three things at the time of transplant. First, first, we need to characterize the cardiovascular abnormalities thoroughly clearly and at the time of transplant. Specifically, the features that confer extra risk, which are diastolic dysfunction and abnormal systolic response. To me, again, that means using two tools, a Swan-Ganz catheter, because a pulmonary capillary wedge pressure is still the most direct and accurate way of diagnosing diastolic dysfunction, and secondly, an echo with offline strain imaging. We need to optimize treatment of these patients with an eye towards correcting those same markers that are associated with worse outcomes, diastolic dysfunction and systolic dysfunction. For me, that means patients who present with high wedges and normal or low cardiac outputs are treated with milrinone. And universally, when I treat them with milrinone, I see a decrease in filling pressures and an improved cardiac output. I'm pretty comfortable treating these things perioperatively because there is a reasonable expectation that these things will improve postoperatively. Finally, from a utilitarian perspective, thus far we don't have day of transplant delisting criteria for patients with cirrhotic cardiomyopathy. And only with better characterization using contemporary cardiovascular parameters can we hope to identify among the very sick patients who present for transplantations, those patients who are most eligible or have the highest chance of success with operation. And that's it, you guys. Any questions?
Thank you, Carl. Great talk, as always. And if there's any questions for Carl, please feel free to pin them to chat and I'll ask. Here's a question. I think it is clear that involvement of cardiology team is paramount. Do they have the same team evaluating the cirrhotic cardiomyopathy patients?
I think I think that is the problem with cirrhotic cardiomyopathy. It is there are no criteria that says this guy is too sick to go on the list, right? Other than an EF less than 45%, we don't look at indices